This is Dr. G. Durga Fanikumar, resident from National Institute of Medical Sciences, Jaipur. This is a case report unraveling a rare angina, an unusual cause of pulmonary hypertension in children. Actually, there is a 4-year-old boy present with a history of fever since 3 months, which is undocumented, on and off, cough since 3 months, dry in nature, non-spasmodic, no diurnal variation, no aggravating factors. Difficulty in breathing since 3 months, which was fast breathing, chest retractions were present, nasal flaring. Severity was waxing and waning during this period, but for last 5 days, difficulty in breathing has increased, now presented even at rest, which brought child to the hospital. No history of weight loss, hemoptysis, recurrent vomitings, recurrent diarrhea, no feeding difficulty, no choking spells, no edema, and no cyanosis. No past history of any significant respiratory illness. On general physical examination, growth and development were normal, vitally stable, but SpO2 saturation was 86 at room air, and grade 2 clubbing present, no cyanosis, edema, rashes. On respiratory examination, mild tachypnea, subcostal retractions and nasal flaring were present. Air entry bilaterally equal with no adventitious sounds, no pleural lobe. On CVS examination, mild tachycardia was present. There were no signs of cardiac failure, no cardiac murmurs. Other systems were normal. Normally growing child with chronic dry cough, progressive increasing respiratory distress with external dyspnea, with no definite history of documented fever, with clubbing, a working diagnosis of ILD was kept. On workup plan, hemoglobin was 9.8, TLC was 5,200, platelet count was 1,52,000, and LFT, RFT were within normal limits. X-ray was done, which was showing diffuse fine nodular opacities uniformly distributed in both the lung fields and pulmonary corners prominent. On 2D echo, enlarged right atrium and right ventricle, main pulmonary artery dilated, size 25 mm, mild PR gradient 53.7 mm Hg, normal biventricular function, which is suggestive of severe pulmonary hypertension. And nextly, we underwent CT pulmonary angiogram, was taken with arterial and venous phases along with high resolution CT of thorax, which showed multiple randomly distributed tiny and central lobular ground glass opacities in bilateral lung parenchyma. These opacities were distributed in all lung fields. The main trunk was dilated with a luminal diameter of 2.5 centimeter. The right and left branches of the pulmonary artery were also enlarged with peripheral pruning of the branches. Concentric hypertrophy of the right ventricle with bulging of the interventricular septum towards the left ventricle was observed along with the enlarged right atrium. Features suggestive of pulmonary hypertension with dilated right atrium, right ventricle. Thus, lung find is suggestive of pulmonary capillary hemangiomatosis. This was a CT which was showing many randomly scattered small and central lobular ground glass opacities in bilateral lung parenchyma. In view of pulmonary hypertension, initially we started oral sildenafil which led to worsening of symptoms in form of increased cough. Sildenafil was stopped after HRCT chest as clinical history and imaging were in favor of pulmonary capillary hemangiomatosis. The patient had no other symptoms other than mild cough and remained clinically stable. As gold standard, pulmonary biopsy confirmation was suggested, however, due to non-availability, couldn't be done. As the patient was clinically stable and the imaging findings were strongly suggesting PCH, histological confirmation was deferred. Regular follow-up with pediatric pulmonologist was planned. Regarding PCH, pulmonary capillary hemangiomatosis is a rare contraventional entity that is known to be cause of pulmonary hypertension and is microscopically characterized by proliferation of dilated capillary-sized channels along and in the alveolar walls. Clinically, it is mostly seen in adults. PCH's main clinical presentations are progressive dyspnea, fatigue, hemoptysis, palpitations, and lateral irreversible pulmonary hypertension and right-sided heart failure. It is characterized by severe hypoxemia, central lobular ground glass opacities on computed tomography, and pulmonary congestion triggered by pulmonary vasodilating therapy. The imaging features include diffuse central lobular ground glass opacities with features of pulmonary hypertension. The disease, the PCH doesn't have a sexual predilection. Unfortunately, the diagnosis of PCH is usually not made until Discussion: pulmonary capillary angiomatosis is a rare cause of pulmonary hypertension that is typically seen in younger adults, but can occur in an age range from 2 years to 72 years. Pulmonary capillary hemangiosis is a rare etiology of pulmonary hypertension characterized by widespread proliferation of pulmonary capillaries within the alveolar walls. Unlike PVOD, which is caused by extensive vascular obstructive process originating from pulmonary venules and small veins. This was the first, Wagenwood et al. Was the first to describe PCH in a 71-year-old woman complaining of progressive dyspnea and hemoptysis. Best et al. Identified eukaryotic translation initiation factor 2 alpha kinase 4 mutations in familial PCH in two brothers.
Start winding up. So, in interest of time, just one question: what is the diagnostic test for making this diagnosis?
Sir,
What's the
diagnostic
gold
test was,
standard?
sir, gold standard is biopsy, sir.
Yeah. So, is it possible that this child has an alternative diagnosis? How confident are we about this diagnosis?
Sir, vasodilating therapy was, it was been triggered, and the imaging was favoring. So this was and we have referred him to the AIMS, but due to the parents' refusal, they didn't do the biopsy.
Thank you.
Thank you, sir.